Okie dokie, everybody. Okay, it is, if you quickly conclude your discussions, we're now going to go and move on to the feedback phase. So, as you'll be aware, there's 4 questions, and what I'll propose to do is to allow about 5 minutes for each question, and I'll let each group lead off on one of the questions, so all groups will have an opportunity to contribute. But I appreciate if you have a last group to contribute, it can feel that there's nothing left to say because everyone said it before. So, who would like to kick off with the first question? What are the main challenges in improving the quality of social care among older adults living with HIV, and what role do you think social care should have in addressing these challenges? Do we have a group that wants to volunteer to kick us off, or do I have to pick someone? Great.
Yeah, great discussion about that. I'm sure you picked up on several issues. One of the issues that we talked about was about disclosure and how much choice is given, and whether people feel as though that choice someday was taken away from them, and people disclose on their behalf. So that was quite an interesting debate about how does that actually work. And there was certainly a feeling that once staff did know, respectfully what we should know, that hopefully you've got better care and disclosed, but then there's the issue of you shouldn't just be told just because they're interested. You've got to involve the person at the centre of that. There's also, we talked about morality and about the impacts on this choice that sometimes sorry. You can talk louder if you want. It's fine. No problem. And we also talked about morality. There we go, very loud. You could start singing. And the impacts on their choice. And what we're talking about, that if you live in a small town or village, that basically people may already know, you might have already been well known about your business. It's very hard to keep things private, and that's got an issue in itself. That goes much wider than just health and social care. That goes back into the wider community. Obviously, a big issue that we picked up on was about the training of staff, and as it was said, that can be very variable across the sector, and certainly having a colleague here from the Care Inspectorate, that in some areas they do it really well, and again, depends which group of staff we're talking about here, because a lot of staff are obviously working in the independent sector, they're also working in the third sector as well, and commissioned services, so it's not just about statutory sector providing these services. And we also added the bit about it should really be talking about health and social care, not just social care, because we're now in the world of integration, we have been for quite a few years. A point was raised as well in the group that we could also build this into service specifications because of commissioned services, so we can actually build in the training and actually be very clear exactly what type of training we actually want from services that we commission, as well as put it into organisational development for internal services, for statutory services. And then for the Care Inspectorate, they can go in and look at the evidence of those training records. So it's about triangulating what our intentions are and what we're actually doing in practice. And that's what we came up with for question 1.
Excellent. Okay, I want to give every group the opportunity to contribute as well, so we'll maybe just go round, but if any group feels that they have nothing additional to add to what's been said, there's no pressure to do so.
Right, I was trying to get a woman to speak, because otherwise it's all men that hogging the conversation, and it's always the way. In terms of the first one, we said budget limitations, competing demands and resources, threats to statutory and voluntary specialist services. Also, we talked about the difference. So on the ground in many services, people are still stuck in they're not aware of what's been happening in terms of developments in treatment and stuff like that. So on one hand, at a strategic level, you have the U equals U message. So people think HIV is rosy, particularly if like people they're having a good life and stuff like that, and people see that's great and successful. Because if you think about back in the 90s when HIV treatment started, suddenly there's massive cuts to all the support services. That could happen again, whereas a lot of the staff in the front line still are unaware of all the advances that have taken place, and the discrimination against people with HIV is real. What else? we talked about people with addiction needs should not be deprived of services because of their HIV diagnosis as well.
Great, let's pass over to the group here.
Okay, I'll take it. I'm just going through to make sure we didn't miss anything. I think the biggest one that we talk about a range of different items, but really listening to what people want and making sure it's patient-centered or person-centered, so making sure that they're involved in that process. But there's also a sense of sometimes people falling through the cracks because HIV status is not enough to make you a priority or to give you enough status. So maybe, whereas like older age or if you have a physical or learning disability might give you an additional edge. Sorry for that phrase, but that will help to kind of give you what's that? Prioritize. There we go. But I think we also recognized there's a very complicated system to navigate and that stakeholders are not always communicating. So there needs to be communication across sectors and services as well. And then finally, one of the challenges, social care as a small S&C is often relying on volunteers. So it's a whole sector that's built on a lot of volunteers contributing their time, but that's always not stable and steadily provided. So we just need to be wary of that as well.
Great, and the final group.
Hi, we had a really interesting conversation on this first question. We talked about funding and confidentiality disclosure has been discussed before. Lack of resources, again, that comes into funding. But we talked about the challenges would be a lack of education across the sector. Although we're working on that now, a lack of collaboration between health and social care networks and NHS, and a sharing of best practice in each. So maybe perhaps as a model can be shared across certain boards. And we could use, there seems to be a lack of using the statutory legislation that can create a kind of goalpost or something that we can use to say, actually, you need to do this because there is an obligation to you to do it in the first place.
Great. Okay, the second question we were looking at is how do we ensure equality in access to social care and health, in particular rural regions, so that it's not a postcode lottery? Who would like to start us off?
So we should expect, regardless of where you are, you should obviously expect the same level of care, regardless of your postcode. And we thought about perhaps attend anywhere services, so that would be the use of kind of improved social media networks, therefore you're improving social isolation, and you would have to use technology perhaps to do that. And again, it comes down to equal education for everyone in care services. Again, that comes back into the first question again. Is that fair enough? Yeah, anything else like that?
Great, I'll pass on to this group.
Thank you. I think what we've highlighted was beyond using technology and embedding that, so the Attend Anywhere service that's used in the Highlands, that's a really good example of how we could be embedding that. I think we spoke about kind of three different models that could be used. So one is linking up and coordinating services, so it's almost a one-stop shop or one-stop clinic in the sense you go to one clinic appointment, but all your other appointments are there as well, or other services are linked in. So this is about co-location and of like other services beyond just health. At one particular spot, but that recognizing this could also lead to fatigue as well when having that many appointments back to back. The second one would be traveling clinics, so looking at more rural regions as far as having either a consultant and a nurse team moving around and offering a clinic throughout a monthly rotation or whatnot. And then thirdly, considering primary care and GPs, so using them as a way to deliver HIV care as an alternative to maybe going to a consultant's clinic. But recognizing overall it's not a one-size-fits-all model, and then we have to make sure that we're being flexible in what we're offering. We did highlight, though, there's challenges between the quote-unquote borders between health boards and local authorities, and that these really shouldn't exist if we're trying to provide that wraparound care, and it shouldn't go back to that postcode lottery. So we want to make sure that anything we're addressing or trying to develop really takes those into account, but make sure that those aren't strict borders.
Fantastic, we'll go to the group at the back.
Yeah, we were saying that, people living with HIV shouldn't really be defined by their diagnosis. We were having quite a lot of talk about, people's choice in terms of disclosure and then choice in terms of access and services. But I think on the same token, it should be recognised that not everyone's experience of living with HIV is the same, and that people should be able to access specialist services and mainstream services, depending on what they want to. It shouldn't be an either-or situation. Likewise, we were saying that, perhaps clinging on to these kind of traditional methods of medication provision and HIV monitoring, i.e. the 6-monthly checks at the specialist clinic and the hospital, actually reinforce the stigma in many ways, and that perhaps we do need to look at more of a primary care community focus in terms of prescribing and having bloods done and things like that at your local GP. But I think that, as we've said, that sort of lack of education and understanding that is present, unfortunately, doesn't really give people living with HIV much confidence that they can access those services and be treated respectfully, or have other practitioners involved to necessarily understand their condition. So there's I suppose a bit of public health education to be done there, and a kind of reminder about anti-discriminatory practice. One of the sort of the things that we were speaking about that the previous group touched on was about the ability for people to move between different local authorities. So obviously in the Edinburgh and Lothians, I've had personal experience of this myself, that in the hospital environment, a consultant will maybe say, oh, I have this person from East Lothian, can you speak to them? And I have to say, well, I'm City Edinburgh social worker, I'm afraid that I can't do an assessment for them because they're not from my area. And then, you can give somebody some advice and try and point them in the right direction, but that whole thing of people not wanting to access services in small towns or villages where they live is a real issue. So maybe local authorities should have some sort of cross-charging agreement so that NHS Lothian patients, and I'm sure that we're not the only area that have this, but that people under the NHS boundaries are able to access services that are under that whole area and not just dependent on what local authority they fall under. I think that's about it. Is there anything else anybody wants to add from our group? No? Okay, thanks.
Great, and we'll just come finally to the group at the front here.
I think most of the thing has been said, but we talked about making sure that everybody was trained. So I think we spent some time talking about training and how to get training to all the different sites. So even rural people work, health and social care workers should be trained to the same level as people in the city. So I think that's mainly what we spoke about for long.
Great, thank you. The third question we were considering is, if you were to develop a project to improve the quality of social care services for older adults living with HIV, what would be considered a success? What would be the intended outcomes? So is there a group that's going to kick us off?
Oh, I'll have a go. Right. Again, it goes back to education, easy access to education network. We talked about how getting these positive messages out to schools and people that are HIV going to schools and sharing stories, which I know that does happen, but I think there's been some challenges with some who didn't allow that message to get into certain schools. I think we'll leave that there, but I think there might be obstacles to overcome when sharing these messages. We really like to build confidence and reassurance to allow patients to share their status, and when everyone's different. And then Robert just talked about a tipping point, about how we all had a tipping point where we went from closeted to open to improving the quality of life. So I think there's really something in that to almost give people who are not sharing some kind of confidence and reassurance that it may be okay. Again, everyone's different, and that's not as easy as it sounds, but...
Okay.
Sorry, and more media exposure of positive messages. So I know that HIV Scotland push out the U equals U and that kind of stuff, but maybe more high profile sharing of that kind of message will help everybody, I think.
Who would like to follow up? What group?
I think we didn't really talk too much about this, but the basic thing we're exploring was that we needed to have a baseline first. So the most important thing was to look at the needs of the people we are talking about. Again, I think it's talking about because people living with HIV would differ from region to region in terms of their social care needs, basically. Some may require, some may not. So I think the basic thing is the baseline services and what their needs are, and then take it from there. That's where we got to.
Okay. Would any of the other groups like to add? No?
No, I agree. I think having a baseline is always important, and this isn't to toot my own horn, but like I think then the assessment was considered that as almost a baseline or foundation to build from, and I think part of recognizing it as when we were developing it is that is a kind of line in the sand in time and capturing like a snapshot of what things are like, and I think we can invest a lot of time and energy in doing another baseline, and in 5 years we'll have a really good understanding of what happened 2 years ago, and it's like it can always do. So I think there's something about being confident enough with the data that you have and involving the stakeholders around the table in a continuing conversation so that everyone's involved to evolve the process together. And I think that's really where we'll see the power in moving it. So I think there's importance to maintain a baseline, but not become a slave to it in the sense of always trying to really get the next data and the best data. So that's just my experience, but I think I totally agree that it's important to have the right data to it.
Does anyone else want to contribute at this stage? Well, that brings us on to the final question we were considering, which is how would you measure a project's success and what indicators would you use? Who would like to kick us off there?
So we're coming really back down to that kind of, what we were talking about, the quality of life indicators, basically. Where do we go from here? Have we got a baseline? How are we going to take that forward? And we felt that, again, quality of life indicators, it's qualities of information you're looking for. And just basically repeating what you've said already, Chris. I think there was, sorry, no glasses. Can we start to create a tipping point for U equals U message and PrEP? Does that kind of create a success? How do we monitor how successful that is in the future? We don't have that. We don't have that wand, I'm afraid, to make it all better for everyone. Movement from
benchmarking.
Benchmarking, yeah. Today compared to before, but again, that's talking about finding out what the quality of life is like with people for living with HIV, and again, we're talking about the 5 or 2 or whatever many years afterwards to check that out. Yeah. Okay. Cool.
Great. Who would like to go next?
I think some people might not have gotten to that last question either.
No.
Yeah.
That's okay. Obviously, we just covered all of the questions there. Is there anything anyone, maybe in reflection, would like to come back to in any of the questions that we've explored? Or any comments that anyone wishes to make that feel need to be aired? Yeah?
It was just really to say that, I think that these days there's so many other providers who are not necessarily care providers and are not necessarily health providers that are under regulatory obligations and things like that, who are also providing services to recipients of social care, and that there really should be a push for commissioning groups within local authorities to also ensure that the services that they are contracting are also HIV ready to be working with people, because I think that there's potential there for a huge gap. That's it.
We've talked time and time again about the Tombstone advert from 30 years ago, and how impactful in negative and positive ways. I see it as actually a really successful public health campaign, but it left us with all the negativity attached to it. That's my own opinion. However, the opinion of the group is that I think with the sexual health and bloodborne virus framework, I think at the time when it was launched, and forgive me because my timeline's a wee bit skewed, I think it was Scott Gov felt that it wasn't going to be appropriate for a public health message to come out about HIV because they thought it was of negative connotations. We thought that actually the time is right now. We've got the science behind us. And I think that the Equals You and PrEP and all the other positive messages are coming about it's now time for a new public health message, and that needs to come from ScotGov.
I get a sense there's unanimity there in that message. Is there any other comments that anyone wishes to make before we draw proceedings to a conclusion? No. Well, in that case, can I just thank all of you for coming along this afternoon. I know some of you have actually been to all of the seminar series, and giving up your time to come along and share your expertise is invaluable to the success of this project. I very much look forward to taking the findings of this series of seminars, part of the wider Living Well 50 Plus project, into the Scottish Parliament, and I hope that when that opportunity arises for a debate, and hopefully in the spring, that as many of you as possible will be able to make it along and attend the debate, and I'm quite happy to liaise with HIV Scotland to make sure that everyone can be provided with appropriate information and obtain tickets for that debate, because I think all of you have made an invaluable contribution this afternoon, and indeed at the previous seminars as well. I would just like to in particular thank Chris, James, Kat and Joyce for their contributions this afternoon. A lot to think about and a lot to reflect on, and just to particularly to thank James for a very powerful contribution that he shared with us. I also just personally want to thank Nathan, Jeff and Dylan for all of their help and support in chairing this. They have put in a power of work to make all of this happen, and I'd also like to thank everyone else at HIV Scotland who's offered their support and helped to facilitate today's events, and also to Gilead again for their generosity, without which this would not happen. It's been a real honour and a privilege for me to chair this series, and I very much of seminars, and I very much look forward to seeing the final product. But again, just thank you to everyone for coming. Thank you to all our speakers and contributors over the last 3 seminars, and a very safe journey home to everybody. Thank you.